So this is the Bifurcation PCI complication session, recognition and solution. I'm chairing together with Sonja Salinger and Dr. Dobrin Vassilev. And in the panel there is Shazia Hussain, Maillard, Viktor Sasi, Matteo Perfetti, which is in the, and Dr. Jouke Dijkstra. So we have 5 cases, 12 minutes. I want to introduce, at the end there is a vote for the best case. What is the best case? How can you judge the best case? So I connect to the previous session about skillness, what is the skillness, what is the technical point that we have to know, and what is competence. So there is difference between skillness and competence. Competence is when an interventional cardiologist knows the topic, knows the tip and tricks, but then he has some experience. So there is the character of the operator combined with the skillness and then the experience. This is the reason why we need some years to become an expert, which is knowledge combined with skillness and practice. So when you have a complication, it can be a preventable complication because you did some wrong things, because we were not a real expert, because you lacked some competence. You have not the character. Sometimes the complication is unexpected. What the difference between the two? When you are a real expert and you have a complication, usually in your mind comes some creativity. This is the difference. So I want to judge you because creativity comes from something that an expert, which is dealing with everything, is not. So he has the creativity, and this I think is what we have to judge in this case. What is the best case based on this? So I want to introduce the first case, which is from Dr. Kasturi, presented by Dr. Kasturi. It's a high-risk PCI with Impella.
Dear EBC Chairman, thank you for giving me opportunity to present at EBC 24. My presentation is high-risk PCI calcific LM bifurcation, IVL modification with Impella support. This patient came to us with a cardiogenic shock, acute pulmonary edema. And when he came to hospital, he was in a gasping status. Immediately we intubated, and there's a markedly elevated lactate levels. Because of the desaturation, intubation was done. Next day, patient became conscious and he self-extubated. So if you see the angiogram, then we did angio shows severely calcified left main disease and extending into the LAD and LCS with diminished flow, right coronary, PDA at the origin about 50 to 60% narrowing. So because the angiographic calcification, what we thought we'll go with bifurcation stenting, whether to go with provisional or left main to do the IVS evaluation. Always see the extent of the block, severity of the block, is it extend to the main vessel or the main branch, side branch, and accordingly you can take the decisions. So always use the intravascular imaging while doing the left main bifurcation, and preferable to go ahead with the provisional stenting because the MACE rate is much lower with provisional stenting compared to 2 stents. But if there is significant side branch disease, long segment disease is there, large side branch is there, definitely we should go with the 2 stent technique. So before doing procedure, because the patient came with acute antival MI, we assess the cath. So right ventricular pressures are normal. There is a markedly elevated LV, and we classified it as a LV dominant shock. So initially IABP support was given, then subsequently we exchanged it to Impella. So Impella, always when you give a protected when you give MCS support, identify classify the sky stage. Is it a DR? It comes at a DRE. And at the same time, early MCS support you give. And at the same time, if patient is having biventricular support, go with even RVs. If patient is having associated RVs, go with early right ventricular support also. And RSC is the key factor to decide what type of MCM support a patient is going to require. And give the inotropes very short period and minimize the duration, and the number of inots are also reduced once you start the MCH. So this is the IAPP and the temporal pacemaker balloon tip, and you see the very significant reduction in LAD and LCX flow. Initially pre-dilated at the 1.5 and 2.5 balloons. So after that, again, we did with the 2.5 balloon dilatations, that is LM, LAD, and LCX. So then we thought that there is significant lesion. We were feeling grating sensation. Then we used IVL, 30 pulses were delivered to LM and 50 pulses to LAD, that is 3.5 into 12 balloon. Subsequently, again, we used the angiosculpt to modify it further. IVL is useful in superficial, deep, eccentric calcium, and even calcium nodules. So, and associated with very low complications. Dissection is low, slow flow, no flow is very, very low. And cutting balloon and angiosculpt definitely advantageous. The intramural hematoma, less chances, the melanocele effect will not be there. And controlled dissection, so less inflammation and more luminal gain. We were negotiating the stent. We were unable to place the stent. Again, dilate with 3 balloon, further modification. Again, retried but could not. Then we used the guide liner with inchworm technique, and mid LAD was stented with 2.75 into 38, and proximal LM to LAD 3.5 into 48 So after stenting, LSE got occluded. So when sudden occlusion is there, always assess the side branch and predict the side branch closure. If the long carina is there and at the same time block button is more, the chance of closure is more likely. And always keep the jailed side branch and jailed balloon. You should be familiar with the techniques like a jailed balloon technique, modified jail. There are various techniques. So operators should be familiar with the various techniques, how to prevent the side branch occlusion. And then we did the LM part. So when you do the LM part, if the part balloon is beyond the carina, it can compress the carina, it can lead to side branch occlusion. If you extend to proximal, it can cause the proximal dissection. That is also associated with increased mace rate. We used a supercross to place the wire into the L6 and dilate with 1.5. Now you got the flow. Again, we thought of opening the side branch with 2.5 balloon, but we were unable to place. And then we used the, see the guide liner, inchworm technique, we placed into the proximal LCX, mainly to place the stent. And the stent was placed with guide liner help into the LCX. And see the kissing balloon using the same stent balloon pulled on, and then 3.5 balloon in the LAD. Then we performed the repart. So repart again, it has to be done once you complete the final kissing. Still, we used NC again to do further kissings, and you should be familiar with the stent expansion capacity and avoid under expansion. LSX is more prone for under expansion, and if under expansion in two stenting has with a very high restenosis rate, so avoid the under expansion as much as possible. That is 24% versus 5.4. And this is the post dilatation with 3 balloon, and we use the OPN NC dilatation further to modify it further. You should know the technique of the kissing balloon, and both balloons should be deflated simultaneously. That is a very crucial point one should remember. And we used 2.5 NC and 3.5 balloon. So this is the final angiogram view. You can see nicely flowing vessels, LAD forward timigrate 3 flow without any dissection. L6 is flowing very well. So careful analysis of the bifurcation with angio and intravascular imaging for block modification, morphology and distribution. And severely calcified lesions require adequate block modification prior to stenting, and anticipate side branch occlusion and prevent the steps to the side branch occlusion. Once occlusion takes place, you should open it and provide the antegrade flow. Use a guide extension catheter to expedite the procedure, and always assess for the MLD max. That is very important. Perform right heart study to decide the how is the RV pressure, LV pressure, what is the what type of shock is there, RV dominant, LV dominant, biventricular dominant. Based upon that, you can choose the MCH, and early escalation and de-escalation strategies required to reduce the MCH-related complication. I thank once again from the bottom of the heart to Chairman, EBC, and all other executive members for giving me this wonderful opportunity. Thank you, one and all.
In this case, we have in the last consensus paper we have all the technique that he used to protect the side branch from occlusion. We start from the jail wire. When you have a jail wire and you occlude the circuit, you can go below the strut of the stent. If the balloon doesn't cross, you can use a balloon in the stented to like an anchor balloon and go below the strut of the stent to reopen. You can use a microcatheter, a Corsair has been described to go in this case. Sometimes when you have difficult anatomy like this, the jail balloon is, there are different from Buzzotta presented the first case many years ago of jailing balloon. There are modified inflated balloon. There are some techniques that can use in this high-risk patient because it was put Impella. So if you have a closure of the circuit, you should be pay attention to all this. I think that in this case, my opinion is that circuit should have been more protected than it was, and then the operator was able to reopen the circuit. But I don't see that a wire in the circuit when the circuit was occluded. So there was some strange, something happened and the wire was removed, or I didn't put a protection wire. So other comments?
I think it's a very nice case and very well demonstrates that left main are probably different than regular coronary bifurcations. Now, what Remo said was quite important, and congratulations for the case that they were able to reopen the circumflex. But if the patient is in cardiogenic shock, I must agree with Remo that it's most important to at least keep it open all the time. I mean, the circumflex is a huge territory. The patient is already in cardiogenic shock. So at least to consider an upfront modified gel balloon, because the plaque moves there where there is some space, and there was no more space other than the circumflex. So I think this is what we do in our daily routine for left main PCIs in acute coronary syndromes, and there is basically no occlusion of the circumflex because we leave some space with the jade balloon, which is undersized. It's about the balloon to vessel ratio 0.8, and that's the reason that we can still, if there's some problem with the opening of the left main LAD crossover stent, we can still some crush or inverted crush we can do. So I think it's at the end it's congratulations because it's a very nice case, but demonstrates the importance of the left main LAD circumflex triangle.
Thanks. The only comment I had was that I didn't follow all the steps, and I was unsure whether or not there was any intravascular imaging to guide this case at the beginning. It seemed that, I mean, the operator's not here, I don't think, to answer the questions, but it seemed we went straight on to shockwave, but we don't really know what the ostium of the circumflex, what the plaque composition was there, whether or not that was calcified, and whether or not there would have been any benefit in shockwaving that as well, because we know that's the area that restenoses in left main bifurcation stenting, and whether or not there'd been some modification beforehand would have reduced the risk of the circumflex going down.
Okay, we can move to the next case. The title is Ho, have got a crush on you, and the presenter is Dr. Schincariol.
So, dear members of the chair and panel, dear audience, my patient was an 81-year-old lady with some cardiovascular risk factors who presented to our institution to undergo coronary angiography due to a stable angina from CCS class 2 and exertional dyspnea. her ECG showing sinus rhythm without signs of ischemia, and the echocardiography showing a preserved left ventricular ejection fraction without wall motion abnormalities. This was the index angiography showing a fairly diseased LAD with a severe stenosis in the proximal part and the Medina 111 bifurcation lesion of the LAD and first diagonal branch. The circumflex artery as well as the right coronary artery showed some disease but no relevant stenosis. So we decided to treat the LAD. We wired both main vessel and side branch with 2 workhorse wires and then performed balloon dilatation of the main vessel with a 2.5 millimeter NC balloon. Dilatation of the side branch with a 2.5 NC balloon followed. This was the angiography after lesion preparation, which shows a dissection involving mostly the proximal and distal main vessel as well as the side branch to some extent. So according to the bifurcation treatment algorithm, we opted for a 2-stent strategy and choose culotte technique for our case. We implanted a 2.5 drug-eluting stent in the side branch. This was the angiography after stent implantation into the side branch. After rewiring of the main vessel, we performed balloon dilatation in order to open struts towards the distal LAD, and then implanted a 2.5 millimeter drug-eluting stent in a culotte fashion. The runoff after the second stent implantation showed some underexpanded stent in the LAD, so we performed additional balloon dilation there. And after rewiring the side branch, we went for kissing balloon inflation. The angiography after kissing balloon inflation maneuver, though, showed a new onset filling defect within the previously implanted part of the stent of the proximal side branch. This was confirmed in an orthogonal projection. We tried intracoronary bolus of tirofiban. The situation didn't change. We then went for stenting of the proximal LAD, and we tried some multiple balloon dilatation of the filling defect within the stent in the proximal side branch. And even after aspirational thrombectomy, there was an unchanged situation of this filling defect. With the patient being hemodynamically stable and asymptomatic, we transferred her to the IMC under a drip of unfractioned heparin and tirofiban, and we got her back 48 hours later for follow-up angiography. As you can appreciate from the follow-up angiography, there was basically an unchanged situation here as well. So at this time, we decided to use intravascular imaging, and we performed an OCT pullback from the first diagonal branch into the proximal LAD, which is displaced here. And as you can see, there is a distal stent edge dissection, which is very extensive and extended in the subintima. Right now, you can appreciate some backscattering in the false lumen, which has also his correlation at the longitudinal frame of the pullback. And basically, what we were dealing there was a partially crushed D1 stent within the subintimal space. Now we are in the proximal main vessel. There is some tissue prolapse at 4 o'clock, and the more we go proximal, you can appreciate throughout the whole proximal part of the stent that there is malapposition and underexpansion of the stent. So, with the aid of a 3D software reconstruction system, this was the OCT Plus software from Pulse Medical, Shanghai, China. You can appreciate the moving image, so that's the right part of the screen. It is a longitudinal 3D reconstruction of the problem we were facing with. The lower part of the reconstruction is displaying the crushed stent within the side branch, whereas the upper part of the reconstruction is the part of the stent in the proximal main vessel with the open struts towards the distal main vessel, which is not reconstructed in this frame. We therefore wired the side branch and implanted a 2.5 millimeter stent in order to exclude the dissection and in order to connect the true lumen of the proximal vessel with the true lumen of the side branch. This was confirmed then on another pullback, OCT pullback from the first diagonal to the LAD. You can see that the section has been excluded and there is well apposition of the struts in the side branch. We are now entering the main branch. There is better apposition and better expansion of the stent right now in the proximal part of the stent. I didn't show it for the sake of time, but we performed some balloon dilatation and optimization of the proximal part of the stent as well before running this OCT pullback. This is the 3D reconstruction of the situation after the second stent was implanted into the side branch, and you can now see both the distal part of the side branch as well as the proximal vessel were expanded. At the final runoff, there was basically no filling defect anymore. We were able to discharge the patient 48 hours later from our institution, and we got her back at 4 weeks for a follow-up. These are both cranial projection showing T3 flow and no signs of filling defect anymore, as well as a good expanded stance in this bifurcation lesion. So my conclusion on this case: bifurcation PCI requires time and a steady mind. Skipping steps often has negative consequences. Should complication occur, early performance of intravascular imaging is paramount to better understand the underlying pathology. Last but not least, thorough understanding and meticulous execution of all bifurcation PCI steps should always be performed to avoid problems and achieve the best result possible. And as Admiral Hopper said, there is nothing to prolong your procedure more than a shortcut. Thank you for your attention.
So you say you avoided a step. Which is the step that you avoided? Maybe the pot?
We skip pot. Exactly.
Yeah. So when you have abdominal rewiring, probably you have an abdominal rewiring. Inadequate pot is one of the reasons. You can have you not go to the proximal part with the pot. You skip pot completely, which is something. Then you possibly, my explanation, you could have been subintimal from the beginning. So you crash the proximal part of the stent that you implanted in the. This is one possibility. So when you implanted the stent in the LAD, you already crashed part of the stent coming from the diagonal in the proximal LAD. Okay. Then when you try to go with the intended culotte to the distal, the crash stent directed the wire subintimally. So you crash completely also the other. The second explanation is that not doing pot, or maybe you were in the correct lumen, but when you rewired, okay, the diagonal, you went distally. We went distally, but the stent were subintimal, so you crashed completely with the kissing balloon, the stent. So probably, yes, pot could be. Should have been done, but even if you do pot, sometimes if you have a stent there and you go distally, but the stent is not opposed, you can still have this problem with culotte. Culotte is you have many steps in culotte, and so is a double provisional. So if you have a proximal wiring of the two, you have many layers, and then if you are subintimal, you can crash the stent, the first stent implanted. Other comments?
Thank you for your comment.
Congratulations for the nice imaging. Remo is absolutely right that pot is mandatory, whatever you do for bifurcation. I think you skipped also one other thing that you have to keep in mind, that double kiss, even if you do culotte, should be mandatory. And also pot, because you see the double kiss crash has very good results because of the double kiss. Now, there are some cases and there are some reports that double kiss culotte is probably also could be competent, at least, or competitive with double kiss crash. And if you do that, you could avoid at least less subintimal passage if you didn't do pot. So if you do double kiss and you do pot, this would not have happened. But congratulations for the excellent images and the way you solved it.
Okay. Thank you.
I think that sometimes we can use only just a stent boost or stent enhancement before imaging, just to help to recognize some complication that can going on. Is the first, and the second, we should keep in mind and pot and dot also, and that an all patient, and we have keep in mind that there is all calcification in his intima. And then when we are looking for coronary artery and stenting, we should keep in mind that we can go on with some complication. And just to look at the stent boost, and after that, if you don't have an imaging at that point, we can stop a procedure, not to move on for complication.
Thank you.
I think the key here was that you should really have done the imaging when you saw the issue, because it's not clear whether that was thrombus. We just assumed that it was. I think there's a question in the audience.
Yep.
Just a comment. I think sometimes we start a case and we sort of make a plan, but you should be able to divert and change a plan according to what happens in the case. Now, in that case, correctly, I would have started off going for culotte. But once there was quite a lot of dissection in the LAD, with a culotte, you have to rewire the LAD, you lose your wire. So I would have converted it to a DK crush, because then your main branch wire never moves, your LAD would have been secured, and I think it would have also made it safer. You know, you were lucky enough that you crossed into the true lumen, but you could have gone into the dissection plane, and it would have been a disaster. So always be prepared to change.
Okay, thank you.
So we can move to the next case, which is stent elongation and fracture, presented by Dr. Narayanan.
Dear Chairman, thank you for the invitation to present at the EBC 2024 meeting. The title of my presentation is Stent Elongation and Fracture. A 67-year-old gentleman presented with progressive effort angina since 2 months. His exercise stress test was positive at low workloads. Since there was no response to multiple anti-angial medications, he underwent invasive coronary angiographic evaluation. Angiogram showed there was a diffuse lesion extending from proximal LAD, extending to distal portion of left anterolateral coronary artery. There was a medium-sized diagonal that is arising from the diseased LAD segment. Obtuse marginal had an irregular 60 to 70% stenosis in the osteoproximal part. Right coronary artery was diffusely diseased from the proximal portion and was totally occluded after a large acute margin. The mid and distal RC was filling from homocollaterals. So in the initial setting, we revascularized the RCA-CTO with a hybrid revascularization strategy with a drug-coated balloon from mid to distal RCA and a drug-eluting stent from proximal to distal RCA, followed by pot with appropriately sized balloons. Angiogram showed good results in RC. On day 3, he underwent evaluation and management of left-sided lesion. We started off with the OCT pullback from distal obtuse marginal, which showed that there was a lipid-rich plaque in the osteoproximal portion, with the critical MLA being 2.17 millimeters square. So the lesion was pre-dilated and stented from ostium with a 2.75 mm drug-eluting stent, followed by post-dilatation with a 2.75 mm non-compliant balloon at 14 points. OCT pullback confirmed that the stent is well expanded with good MSAs at all sites. A pullback from the distal LAD showed there was a lipid-rich plaque extending from distal LAD with a critical narrowing at proximal to the septal origin, where the lesion MLA was 2.06 millimeters square. The distal reference vessel diameter was close to 2.4 millimeter, and proximal reference was 3.2 millimeter. The osteoproximal LAD and the left main were free of luminal narrow. So with this data, we pre-dilated with a 2.5 mm non-compliant balloon. I sized the stent according to distal reference and placed a 2.5 to 34 millimeter drug-eluting stent from ostium of LAD, followed by pot proximal to septal origin with a 3.5 mm non-compliant balloon at 18 atmospheres. The angiogram after stent deployment showed a critical discrete narrowing distal to the stent, and the OCT confirmed that this was a stented dissection just extending to media, an axial length of more than 2 millimeters. So that area was covered with a 2.5 mm drug-eluting stent, followed by post-dilatation 18 atmospheres. The repeat OCT showed well-expanded stents in the mid and distal LAD, but to our surprise, the osteoproximal portion of the LAD had shown absent stent struts from 2 to 8 o'clock position, and stent appears to be elongated, and there was a deformed, crimped stent in the mid to distal left. So at this time, we rewired the circumflex and pre-dilated from left main to LAD with a 2 mm balloon, but our attempt to negotiate a 2 mm balloon from left main to circumflex was not successful. So then we again pre-dilated from left main to LAD with a 2.5 and 3 mm balloons, and then we were able to take a 2.5 mm balloon into the circumflex and approximated the crimped stent completely in the left main wall. Then we placed a 3.5 to 18 mm drug-eluting stent from proximal left main to LAD, followed by pot with a 4 mm non-compliant balloon. Circumflex was reaccessed, followed by kissing balloon with 2.75 mm and 3.5 in LCX and LAD respectively, followed by repot with a 4 mm non-compliant balloon at 18 atmospheres. Angiogram showed very good results, and OCT confirmed that there is no floating struts in the mid to distal left main, and the crimped struts has been opposed to the cell. So the new generation drug-eluting stents have strut thickness ranging from 60 to 80 microns, and this reduction in the strut thickness is primarily done to improve the deliverability to the distal tortuous lesions. But in the main process, it has compromised the resistance to radial and longitudinal deforming forces. Bench-side testing have shown mean absolute stent elongation by as much as 2.2 mm and relative stent elongation by as much as 9.5% when you overexpand with a pot bed. And the degree of overexpansion increases with each 0.5 mm increment in the size of pot bed. In the bifurcation lesions, we usually size the stent according to distal reference. So the stent is likely to be underexpanded and Maillard in the proximal portion. So when we place the pot balloon exactly at the carina, the balloon may slip back and can drag the Maillard stent struts and lead to stent elongation. When we are too fast in withdrawing a deflated stent balloon, then it can interact with the potentially underexpanded stent in the proximal vessel, and that can lead to stent elongation. Recent series have shown that the underlying plaque morphology has a role in facilitating this complication. Lipid-rich plaque, as in our case, are reported to have associated with higher degree of stent elongation by as much as 6.4% when compared to fibrous and fibrocalcific lesions. So in short, stent elongation has to be considered while performing pot. Lesions which need precise placement of stents like aorta vessel ostium and across near the major branch vessel ostia, the possibility of stent elongation has to be kept in mind while deploying the device. And pot balloon need to be allowed to fully deflate before withdrawing into the guide. And imaging helps to detect lesion morphologies, which will alert us to expect or to anticipate this complication. And finally, the order of performing pot, by performing a proximal to distal pot as opposed to distal to proximal, which you usually perform, may minimize the degree of stent elongation as reported in some studies. Thank you for the patient hearing. I'd be happy. Any questions regarding this topic?
I think you answered all the questions that because we know from the TOT paper in 2022 that this is the elongation, and the elongation is 2 mm every 0.5 mm of pot. But probably a contribution was the deflation time and the balloon that you use for pot. So the wings of the pot balloon, if you don't wait after deflation of the balloon, the wings of the balloon can be trap the ostium, and when you remove the balloon too quickly, you elongate the stent. And I have a case of a stent extraction. I extracted the stent completely after I did the casing. After I did the pot, I did the casing, the pot, and then because I was used to remove the two balloons together from my many years, in all left main, you remove together. Probably the balloon was twisted, and there were 4.0 balloon and 3.5 balloon. Probably the two twisted balloon with the wings, they catch the stent. It was a provisional, and I discovered that there was something in the tunnibus, and it was the stent attached to the two balloons. And so the stent was not anymore in the left main, but was with the two wires inside. So you can, with the balloon, you can even extract the stent. So you put a lot of attention. This elongation is favored by balloon, deflation time. You have to, and also the type of the balloon. This is the mechanism in this case. So Todd proposed to, when you have to this ostial lesion implanting, to don't go exactly at the ostium, but leave 2 or 3 millimeters if the ostium is not a disease inside the LAD. So if you have elongation, we will stay in the LAD.
Dr. Narayanan, congratulations for the very nice case, but subsequently you answered all the questions that were maybe probably from the audience and from us. Now, I think what was the very good point, though, that maybe we should consider proximal part first to secure a stent placement and stent, not to have elongation of the stent, and I think then do distal part. So I think that would be quite a good idea, and maybe there would be some studies that we should conduct just to prove that point, because that would be an excellent idea not to have stent elongation and do part first and the proximal part.
Maybe to add that sometimes we should avoid of overexpansion of proximal part of stent and to avoid to make some bottleneck of proximal part of stent.
It's also depend of the quality of the platform, you know. Not all stents are equal for bifurcation, unfortunately.
This complication is described more with stent with 2 links compared with stent with 3 links, because with the 2 links you have more deformation when you remove the balloon. So when you use 2 link stents, you should pay more attention to this complication, to this elongation. No, you have to use, because sometimes you have to use, and you are. But you should know the tip and tricks using they are more flexible. In bifurcation, sometimes they are useful because you open the strut better, but they are more prone to elongation.
I do wonder also, you had a 2.5 stent, if I remember correctly, and then dilated it with a 3.5, which to me, I don't know which platform you used, but that seems a bit excessive in terms of post-dilatation in a 2.5.
Actually, the packet insert permitted the dilatation up to 3.5 for this particular stent. This was a 2.7 stent, and the packet insert permitted the flaring up to 3.7 millimeter.
Just one question. The stent length and the deformation was measured by OCT?
Yes. This was detected. Actually, we recognized that stent elongated, and it was in the left main from the OCT pullback only. Nothing was visible on the stent boost images and the stent enhancement.
Yeah, then you have to be careful, because you have a cardiac motion artifact, and it was very clearly seen in the longitudinal view that you showed. So partially, your stent elongation might be due to this cardiac motion artifact. So maybe we could reinterpret the case.
So if there are no other questions, we can go on with the next case, which is the Engie stent, reverse culotte, save the day, and Dr. Richa Sharma will present. Please go on.
A very good morning, dear Chairman. Thank you for the invitation to present at EBC 2024 meeting. The title of my presentation is The Hanging Stent, Reverse Culotte Saved the Day. So this is a 65-year-old gentleman who was a known case of hypertension, and he presented to us with acute onset chest pain. Diagnosis was non-STEMI, in which we can see ST coving with T inversions in anterior leads. Patient's echo was suggestive of an ejection fraction of 42% with LAD territory hypokinetic, and he was hemodynamically stable. The patient was explained for angiography and was taken under informed consent for the same. This was his angiogram, which showed that L6 was normal. His RC was also normal, while LAD D1 bifurcation was seen, where 111 classification, wherein the ostial proximal diagonal was critically defeased. And in this particular view, we cannot actually see the size of assess the complete size of the diagonal. So Now, the plan was to go with a provisional finger stent strategy as per EBC recommendations or a bailout of TAP, TN protrusion, if required. I knew that the ostia of the side branch was highly diseased, and if I just go with the direct stenting into LED, the vessel might cut off. So the plan was to just do just pre-dilatation of the diagonal as well. So we took a right radial axis and a 6 French EBU guide, parked two wires run through in LED and whisper in diagonal. And to secure this diagonal, D1 was dilated with a 2 into 10 millimeter balloon, semi-confined balloon at 6 atmosphere, kept there for almost 20 to 30 seconds, so that it will create just a space. And adequate TIMI 3 flow was achieved in the diagonal after this. Mid LED was also pre-dilated. And thereafter, we took a 3.48 millimeter DES, checked in multiple views in LED and deployed the same. There was no distal dissection seen in LED. Diagonal was flowing, but I was not very happy. I just saw that the branch is quite huge and not a smaller one. Ostia is severely pinched, and maybe some micro dissections have happened at osteodiagonal. So we plan to go ahead with our technique, with our initial plan, bailout plan of TN protrusion technique. First, we did a pot with a 3.75 into 10 NC balloon in the proximal part of the LED stent. And then whisper was recrossed into diagonal, keeping this 3.5 balloon in LED. And I took a stent of 2. First, I dilated the diagonal stent struts with a 2O balloon, and then took a stent of 2.5 into 28 millimeter into the diagonal. At this stage, nightmare actually happened while pulling and pushing the D1 stent to position it very precisely into the, keeping minimal strut into the LED. The shaft of the stent actually broke from soft part of the balloon within the tight catheter. Stent, along with its balloon and its softer part, was lying hanging uninflated in the diagonal. So what next? Either I could snare the broken stent, but it was the radiolucent part, and from where actually it broke down, I didn't know that. Or I may balloon trap the whole system because I already had a balloon in my LED and remove the whole, pull back the whole assembly. I can also do twisting of wires and maybe create that much of weight, that would create that much of weight, which will pull the whole stuck up system. Or maybe crushing of the stent, but in our case, crushing of stent was out of question as softer part was still there inside. So I immediately took the LED balloon of 3.5 millimeter, which was there inside the LED, back into the guide, dilated it at 4 atmosphere, and retracted the whole assembly. The whole assembly was pulled out. Unfortunately, because I already had a LED stent inside, the uninflated D1 stent, it got stuck within the LED stent struts, while the balloon with a bit of soft part and both the wires, they just came out. Diagonal stent, it got crumpled into the LED stent strut, and a part of it was stretched into diagonal, uninflated. This was a nightmare for me. Now what to do? So the options to salvage the situation, first aim was to save my LED by rewiring the LED, and maybe after that the diagonal needs to be taken care of. Fortunately, my luck was there, and patient was hemodynamically stable. That gave me time to actually fight with this situation. So now I tried to cross the wire into LED, but did multiple maneuvers. Wire couldn't cross the LED because of the crumpled stent of D1 and LED both. And but fortunately, my whisper wire, it was again and again, it was easily getting crossed into the uninflated D1 stent. And so we parked one whisper into the diagonal, the uninflated diagonal stent. And with further maneuvering, again and again, we tried to cross the LED wire that maybe at some point of time, it may cross not behind the stent strut, but through the stent strut into main true lumen. So we parked our LED wire. We didn't know whether it was through the true lumen or not. We tried to cross with a very small balloon, even the smallest 0.8 Nic nano. We tried to cross it, but the balloon couldn't cross into the LED. So that showed that our LED wire was behind the stent struts. So now I plan to dilate the diagonal stent struts. D1 was first dilated with a 1.5 into 10 mm balloon. Again, I tried that because this 1.5 mm might have created some space. I tried to cross the balloon in LED, but it didn't cross. So the plan was to dilate the Devon stent completely, initially with this 1.5 followed by 2 and 2.5 mmNC at higher pressures of 26 atmosphere. This was followed by the dilatation of the diagonal stent, which was hanging in the LAD with a 3.5 mm balloon at 24 atmospheres. Now our diagonal stent was fully dilated. We tried to cross 1 mm semi-compliant balloon through the LAD stent struts, but to no avail. So LAD wire was removed so that we can recross again. But it was a difficult wiring into LED, and it was not crossing. The wire was not going into the LED through the true stent struts. It was always going behind that crumpled portion. Now what we did was that we parked the LED wire into the diagonal as well, and our balloon was crossing on that. 1 mm, 1.5 mm balloon was easily crossing into that LED wire. That means that LED wire was that wire was in the true lumen in the diagonals. So after passing that LED wire into diagonal, kept the wire there and took out our whisper wire, which was already in diagonal, and through the stent strut, we went into LED. So now LED stent struts were dilated with a 1.0 and 2.5 mm NC balloon at higher pressures of 18 atmospheres. This was followed by, we first actually put the stent from ostial to proximal LED at 3.5 into 12 mm disc because many dissections and distortions were happening over there. So after that, we took 3.5 mm NC in LED, stent was post-dilated hole, and we also took a 2.5 mm balloon into diagonal, and final casing balloon inflation was done with the same. Thereafter, pot was done with 3.75 mm balloon. This was the final result, which showed TIMI3 flow, and all the diagonals and branches, they were flowing pretty well. Patient was hemodynamically stable. Patient was discharged on equestrian and ticagrelor after 3 days. So the incidence of stent dislodgement, it ranges from 0.3 to 8%, and dislodgement of stent can be secondary to extreme coronary angulation, highly calcific coronary artery, inadequate bed preparation, direct stenting, or interference by previously deployed stent. In our cases, 2 things happen: breakage of the stent shaft and dislodgement of stent due to interference with previously deployed stent at proximal to mid-LAD. We can do percutaneous stent retrieval by a small balloon technique or a double wire technique or loop snare. If stent retrieval is not possible, we can take a new stent and it can push the previous stent against the vascular wall. But in our case, this step was not possible. And also because of the previously placed stent in proximal to mid-LAD, the snare was also not possible in our case because of the presence of that previous stent, the whole of the diagonal stent got crumpled and elongated. Patient was hemodynamically stable, so it gave us time to intervene by recrossing the wires and performing modified reverse culotte. And thus, all these strategies of bifurcations, they should be known to interventional cardiologists because whatever may come handy at what time, we never know. Thank you.
So thanks for presenting this case. And do you have an explanation why the shaft, so you torque the catheter too much? Probably you give a rotation to the catheter, not only pushing and pulling, but...
First of all, a very good evening from India, and thank you for letting me present here. So actually, while going inside the catheter, while I was taking the stent inside, I was feeling some kind of roughness, and I said to my technician as well that whether stents are also being made ET or something like that, I said to them. I was not feeling very happy while taking the stent inside. I don't know that particular batch was defaulty or what. That was one thing. The second thing was that I had a 6 French guide. I didn't have a 7 French guide. Tap can be done in that, but maybe that smaller luminal diameter of the guide can be issue that while I was pulling and pushing and positioning this stent, this might have caused a problem that it got broke up from the softer part. So these were the 2 reasons, because once I crossed the wire through the stent strut of LED, I pre-dilated with a 2010 balloon, which could easily get past, and dilatation was done already in the diagonal.
Yes, this is then you solve with this, when you remove you have no other choice than removing together everything with the trapping balloon in the guiding catheter, and you lose the position of the LED. And then another solution was just the velocity. When you see that the stent doesn't come back, maybe you can, I don't know, because you have to remove everything, and this is the solution.
Was actually hanging. Otherwise, snare could have been used, but because that's the radiolucent part, we didn't know where actually it was there and how much it is left inside the guide. Once it got removed, we could see it. I didn't have that. I don't have that picture of that, because that was a panicky situation for me. I just knew that this nightmare has been created, and patient will develop stent thrombosis if nothing is done.
Yeah, we are lucky to be able to go inside the stent with the wire. This was really almost unbelievable to go inside and then convert in a culotte in inverted culotte. At the end, you were able to go, and then the solution was creative to just invert to create this. Yeah, you were lucky.
Dr. Sharma, congratulations for the nice solution for this particular case. And just one remark, that we are coming back to the original question, that should we put 2 stents in such a place? So I think that's why probably provisional stenting that has less problems. And even though we don't see, if you don't have imaging for doing such a bifurcation, even as an LED diagonal, you don't see the protruding struts. How does it look inside, even the LED? So, and one other remark is that in our experience with younger fellows, we had a lot of problems, such cases, that losing stents. But if it's too far, we were always unable to have it retrieved, even with the snare, coronary snare, or whatever. So I think in that particular case, you have to settle for crushing that particular stent, wherever it is, and do the bifurcation once again. And one more remark is that with the whisper wires, we are always afraid of. And I always have our fellows and younger colleagues saying that I think that particular wire is not such a clever wire. So it was very lucky to recross with that, because that goes just everywhere. But congratulations for the nice case. These are just remarks that maybe we should keep in mind, that maybe just putting 1 stent and keep it open strategy would quite be helpful, and maybe have the patient 2 months, 3 months back on the table and see how the diagonal is doing.
Yeah, just, I mean, it was a great case. Just one comment. When you were struggling to go down into the LAD, you had already dilated the diagonal. I think rather than pulling back and trying to then, you said they were both in the diagonal, so you pulled your diagonal wire and you lost the diagonal, and thank God you got into the LAD. But I think that would be an ideal case for you to use a dual lumen catheter. You keep your wire in the diagonal, come out the side and wire the LAD.
So, sir, what I did was, once this all happened and I dilated completely the diagonal, I kept the diagonal wire there itself, was trying LED to go into the LED, but it was not going. So took that LED wire in the diagonal, confirmed with the 1.5 balloon whether it was crossing or not. It was going through. So kept that LED wire into diagonal and brought back the diagonal wire back into LED with that reverse loop kind of a technique, so that this may fall into the now true LED through the true stent struts and not behind. Because coming proximally, it was always going behind the strut. So coming from diagonal, it may hit somewhere through the strut and go into the diagonal. And then with the 1.0 balloon, we could cross with the 2. Followed by 2.5.
Thank you. We go on with the last cases, and then we vote at the end which is the best. So the last case is uncovering the unseen. It's Dr. Protty is presenting.
Thank you. If I can have the slides up. Thank you very much for hosting me today. My name is Majd Protty. I come from Southeast Wales. I've put a dot on the map there for you. It's a hospital called the Grange University Hospital, where I did my 1-year fellowship last year. I also realise that I'm the only thing standing between you and dinner, so I'll try and keep this short. So it was an 81-year-old gentleman who presented with symptoms of angina on a background of previous left main stem PCI, which was a decay crush done by a seasoned operator with a good 5.0 pot under Ivor's guidance. And that was 18 months prior. His symptoms resolved after that procedure until 2023 December, when he had recurrence of his symptoms. He was seen in clinic and then eventually filtered through to the cath lab for a procedure, angiography plus or minus proceed. He had a past medical history of hypertension, hypercholesterolemia, and being an ex-smoker, in addition to his previous instrumentation. I must say I didn't include on here that his echocardiogram showed a normal ejection fraction. He had a right coronary artery that was very small and vestigial. He's a left-sided dominant circulation. So knowing this and knowing his previous stenting procedure, I went up front with a 7 French sheath in the radial artery and a 7 French EBU35 guide. And I took the first picture, and this is what it showed. You have this critical ISR in the circumflex stent. So I wired it, and I thought I'll just advance a 2.0 semi-compliant balloon, but it was not going. The guide was backing out. I thought maybe it's some support issues. So I thought that's fine. I'll just take a microcatheter and change my wire to a slightly more supportive wire and see whether the microcatheter will cross and create a channel. But as you can see, the microcatheter was taking a funny course, going up and then back down. So I wasn't sure what's going on in here. And I didn't want to lose the progress that I already had done. So what I did is I pinged another wire down the stent, I brought a small balloon, and I stent boosted. And as you can see, the microcatheter is going behind the nicely done 18-month-old 5.0 potted left main stent. So the position is abluminal. So the positive about this picture is that I know that I have a wire that appears to be in the true lumen, endoluminal, down the LAD with a balloon on it. So what I did is I retracted my microcatheter and the wire back into the guide. And there were many options presented to me, but there was a split-second decision. I was feeling optimistic, I suppose. I did this. I took the wire back into the microcatheter. I made my guide as coaxial as possible, and I pushed the microcatheter forward without a balloon leading it on. The rationale, I thought at the time, was that it's bulky enough to hopefully not go behind the stent struts and follow a wire. And I stent boosted, and it was the right thing. Maybe I got lucky. Maybe it's a new technique that I need to patent. But sure enough, now I've got a microcatheter in the LAD. I advanced the wire, of course, and pushed it up and down the LAD to make sure it's free, and stent boosted here to confirm that it's there. And that rescued the situation, and now is now endoluminal. So I was able to wire the circumflex, balloon it with a 1.0 and a 2.0, and then IVUS. And you can see the stent in the circumflex is nicely opposed, but then you get to this area in the proximal circumflex, which is coming up now, and you can see there is a lot of calcium, aggressive neoatherosclerosis within that stent. A nice figure of 8 at the confluence, and a nice stent in the left main. So this is the still that shows the problem, the calcified neoatheroma. So serial dilation, cutting balloons, and IVL, and then decided to follow a TAP strategy by deploying a new stent in the circumflex, and we can discuss whether there's multiple options that we could have done here, but we were not very sure as to whether there's tissue protrusion leading to this aggressive ISR, whether there's a lack of coverage of that area, or whether there's a mechanical problem. So we deployed another stent of a different manufacturer with a different polymer and a different drug, and we tapped it. And then we brought the balloons back so we can center the metallic neocarina and use this opportunity to go to high pressures to try and push that left main stent as far as possible against the wall. And this was our final result. And we're very happy with this. So the learnings that I made from this case is that abluminal wiring is a risk even after 18 months of the original osteal left main stent, which was done under IVUS guidance with a good high-volume operator. But stent boost was really useful here, and I think it was mentioned earlier when we were talking about abluminal positions. Stent boost is a very cheap way to help you detect abluminal versus endoluminal positions. And there's no added expense to it. Most devices, Philips or Siemens, will have a technology that allows for the stent enhancements. And as one of my trainers would say, it is the poor man's IVUS. So we should use it more often if we are in doubt. Thank you very much, and I'll be happy to take any questions.
There are two. There are. Yes, go.
So in the index procedure, was there a calcified nodule in the circumflex? Because eruptive nodules can grow like that through a very well stented segment. So in the index procedure, do you know?
No, I looked at the images before because I wanted to see and it was definitely calcified and was IVUS, and there was a nodule.
Sorry, okay.
And they modified it as much as possible, but it's very likely, as you said, it's eruptive, so it's bioactive and probably protruded through and developed more.
Thanks, that was a great case. I don't know if you did do any imaging during your one, which wasn't shown, but also you went behind the stent originally, which means that stent is not well deployed. I know you did a kiss, but did you do a pot at the end, and did you get it up the right size? Because you haven't shown that.
No, I did not do a pot. We debated it, but we were worried about disrupting the metallic carina. So we tried to bring the balloons back as far as possible into the left main and go high pressures to abut it. And then the IVUS that I showed after showed that the stents were opposed. But maybe you're right, maybe the 5.0 wasn't enough, maybe I needed 5.5 here. But we made that balance in an 81-year-old gentleman who's been on the table for quite some time.
Thank you very much for the case. Sometimes even if the stent is well deployed, well opposed, you have some struts that prolapse in the aorta, and you may go through these struts in the left main.
I think this is exactly what happened here.
I think
and
that
on the IVUS, you can see the struts sticking back.
Yeah.
And we do this frequently. Even if you are nailing the top shelf of the left main ostium, the bottom shelf will always have stents hanging out, and we intentionally leave 1 or 2 struts out. And I suppose when your guide comes to engage, it's never really coaxial inside the stent, and wherever your wire goes, you will take it. And on this occasion, they went behind the stent.
Exactly. Yeah.
Thanks, Majd. That was a great case. Just a quick question. You were talking about the stent boost being the poor man's IVUS. Do you think the course, you could only see it on the stent boost because you had the corsair following it? Would you have been able to see 2 wires and been confident that one of the wires was abluminal just on a stent boost?
So we need 2 dots to be able to see the stent boost, of course. So I needed a second wire with a balloon in situ. Of course, the second wire could have also been behind stent, but I'm seeing it in a 2D image there. But I think stent boost here was very helpful because I didn't want to instrument this any further, particularly as I didn't know where my second wire was either. So when I passed my balloon and it went in, I was able to stent boost. So that's why I did it.
And congratulations for the treatment of this potentially tricky case. And but just wondering, did you do a final IVUS since it was on the table after everything? Because I'm not sure. Did we see those pictures?
No, we didn't.
Because I saw only the angiography.
Yeah.
But you see, it is quite debatable if you don't do POT. Since 2 years ago, there was probably an insufficient POT before, since you could cross the corsair quite easily towards the circumflex. And if you don't do imaging, you don't do measurements, and then maybe 2 years' time, half year, 6 months' time, you could experience the same. So I think it's, and we see that POT is probably the most important step finalizing a bifurcation PCI.
I think
so
that's a very reasonable
that's
point.
some criticism just because since IVUS is on the table, doesn't make a difference. There's no contrast, so how much the patient is lying. And I think it's a crucial point that maybe for others to at least learn from this, that left main is always different than regular other bifurcations. And since you have, and maybe you are going to have a shape of an 8 or some elliptic shape, and there's going to be neoateroma also, maybe 6 months' time, 2 years' time, we don't know. But if the patient is probably going to be staying alive because there's quite a roomy left main, so it's not going to be very fast to have a thrombosis or have some little complications. But that's a little criticism that final POT and final imaging, that's
I
since
think that
it's
would
on the table.
Yes. Well, at the time, I didn't know I was going to be presenting it here. Otherwise, I would have definitely done the IBIS at the end as well.
That's accepted, okay.
We
Answer
certainly,
accepted.
because we didn't want to pot and interfere with the metallic neocarina, we didn't feel that the IBIS was going to add much. But I think you're right. There's value here in considering a pot, even if it's a shorter balloon, even if it's hanging out away from the metallic neocarina.
Congratulations for your cases. And I would ask you if you were able to feel any tactile feedback with your first guide wire, or if it was a polymer jacket. And the second question, according to the previous comment, aren't you afraid that the passage of the microcatheter could deform the stent, could distort the stent, so the need for a new pot?
No, you're right. So the wire was meeting resistance at the nodule, and I couldn't progress it as far as I wanted. I progressed it down the distal vessel, but that's why I felt I needed a more supportive wire when going with the microcatheter. And sure enough, towards the end, after serial dilation, you needed a 1.0 to go. It's very tight. And you're right in terms of the corsia deforming it, but then the IVUS that I showed gave us some confidence there. It wasn't deformed and malopposed as much, although the valid point of a report at the end is always something to consider.
Thank you.
Okay.
I'm not sure the second stent is the ideal treatment for calcified nodule. I mean, perhaps doing shock wave there, and
which we've done,
and did a DCB or something. But second stent, I'm not sure the most ideal. Nobody knows what the ideal treatment is.
No, you're right. So we had this discussion. So I had it with one of our senior colleagues as well, and we just weren't sure about the coverage of that area, whether there's any mechanical problems, because the calcium dropout didn't allow us to see the stent struts behind it. We weren't very sure what the mechanical situation is. But of course, this is a common place for stents to fail, despite how well you do, particularly if there's an eruptive nodule.
I will make a short comment. Thank you for your presentation. So don't forget the ostia of left main is very easy to displace, deform, modify with the guiding when you come. So the first lesson in when you cannot cross, there is always a reason. And you've done it very well. Take your time, pull back everything, take the good way, and make a new pot. Most probably the stent is deformed, maybe not enough deployed at the first, or mobilizing with the guiding catheter. And kissing is mandatory with two stents for me. I'm not a full adept of two stents technique for reconstruction of bifurcation. I prefer a provisional T. And we're working with a new technique, how to set the stent without crush, no gap, no overlap, to obtain the best reconstruction. Bench are running. That will be another study. Thank you for your presentation.
Thank you. Thank you.
So we have to vote. I don't know how to vote. Oh yeah, you have to vote to use culotte to assess the vote joint discussion. Okay, you have to use your iPhone and scan the QR code to assess the vote program. $27 voted. Maybe we are. I think that the Richa Sharma is the winner, because it's even if you if you don't. So she is not here. Is here. And there is the prizes on the podium, and congratulations for your skillness and competence in doing this solution of these complications. It was very didactic. Thank you.